So I'm a neurologist by primary specialty and a neuro-ophthalmologist by sort of tertiary level specialty. So I do see people with Parkinson's disease and Parkinson-like conditions, and because I am an ophthalmologist, it's usually because of the eye connection, which I think probably for some of you sounds a bit strange. It's not the first thing that comes to mind when people think of Parkinson's diseases is the eye and vision. It's always motor problems, or maybe people worry about their cognition, but a lot of people think about vision. But there's a sizable number of people that do end up trundling their way to our clinic, and I'm going to talk to you a bit about some of the things that we do see that actually aren't that uncommon, and then a few other things that are a bit speculative. So let's see, I have to use the arrow keys here. So this is kind of the outline of the kind of things I think we'll talk about today. We'll start from probably the common and sort of more mundane things, and then move away to some of the more interesting and strange things that happen. So ocular surface problems. I mean, it's not really a neuro-ophthalmology problem. This is the kind of stuff that is pretty common in society, and usually is handled by optometrists and general ophthalmologists. But what the heck, we see it too. So we do need to know how to look for it and give some common sense advice. Then there are eye movement problems, and this is the kind of thing that perhaps a general ophthalmologist and optometrist may be less familiar with, the kind of eye movement things that we see not uncommon and can cause problems and symptoms that actually some of them have a reasonably easy fix and others not so much. And then finally we'll talk about vision in Parkinson's disease, and even venture to maybe some of the brain issues that could be of issue. So anyway, I'll try to keep my eye on the chat screen as well. So if you have any questions as we go along, you can pop it there. If for some reason I miss your question, I'm not sure how you can bomb me, but Miriam can probably let me know. So what we talk about, what we mean by an ocular surface problem is, well, it's the front of the eye, and most of the time we're talking about the cornea or about the lids when we're talking about this. And the two most common problems that we see in Parkinson's is dry eyes and blepharitis. So I'll let you know what blepharitis is in a second, but we'll talk about dry eyes. I think the idea of dry eyes is fairly self-evident. This is where you're essentially not having enough tear film to keep the front of the eye well lubricated. You do need that. That's partly what blinking is all about. It's like the windshield washer, the windshield wiper of the eye. Trying to keep that nice tear film over the cornea. And it's not an uncommon problem among people as we all get older, but it's even more of a problem in Parkinson's for a number of reasons. One of which is the fact that people with Parkinson's don't tend to blink so much, and so you don't have the windshield wiper going. And also, the blepharitis that we see tends to kind of make the tear film perhaps less efficient in keeping the eye moist. So in the front of the eye, one of the things about the cornea is that it is quite a pain-sensitive structure, which is why nobody likes to poke in the eye with a sharp stick. And if you have a drying out of the corneal surface, it can erode the surface, and that is uncomfortable, and that gives you that burning, gritty feeling of as if you got is decreased blinking lack of dopamine? Well, that's a good question. I don't know how exactly the dopamine connection works. We don't think of dopamine as a specific neurotransmitter for the motor response of a blink, but it's probably something to do with keeping that kind of normal rhythm going. I think most of us are familiar with the appearance of people with Parkinson's in that they tend to maybe not move their eyes too much. So it's almost like a bradykinesia or hypokinesia of the eyeball, if you want. So that's the way I sort of think about it. So if you have reduced tear formation and you don't blink, it's kind of a double whammy. And if it's uncomfortable enough, you get the feeling that you got something in your eye, like I said, somebody threw sand in your eye, a gritty feeling. Not everybody with dry eyes has that, which is kind of curious, but most people do have that, the irritation. And because the eye is irritated, what the eye does in response to pain in the eye is it creates a reflex response to the lacrimal gland, which causes you to secrete watery tears, which is weird because somebody who's actually presenting with a tearing eye and water flowing out of the eye actually might have a dry eye problem. And that's sort of counterintuitive. But if you remember that the watery tears are the reflex response to erosion because you're not making the normal mucus tears that keep your eye from drying out. That's why you have this tearing. So in addition to tearing and the gritty sensation, if the cornea is not smooth anymore, then things can look a bit blurry. And the cornea is the window on the world. And if it's not smooth, the transmission of light through that is going to be a little bit like through frosted glass, as it were. So intermittent blurring of vision, especially with prolonged reading or tasks where you're trying to do some vision task for a long time, that's often a dry eye type of a symptom. So that's a typical condition that tends to matter. All of us tend to blink less when we're engaged in a heavily concentrated, focused task like reading, especially if it's not very interesting material. Somebody can vouch for that symptom. So think about it. If you read for a while and you develop either blurring, grittiness, or start to tear, that might mean that your blinking is deficient and your tear film is not up to the task. This is what we see when we try to look into somebody's eyeballs with a complaint of dry eyes. Now, I'm not sure. Is my mouse visible on your screen? I don't know. But anyway, if we look with a magnifying kind of instrument at an ophthalmologist's office, and we put a little bit of dye in, which is what the green stuff is on the left there. The green is a bit of a fluorescent dye. We shine a blue light onto this. You can see the green waves or smears. That's the tear film. Okay, and that's okay. You're supposed to have that. But should be probably more of a uniform green. If it starts to break up and develops little islands of darkness in there, then it's not creating an even coverage. And the little bright yellow specks are zones where, over here, does that work? That cursor? Yeah. Those little bright yellow specks, those are little spots where the cornea is eroded away, and that's uncomfortable. Okay, that's what happens if the tear film just doesn't quite, lets the cornea dry out. On the right-hand side, you see another way of showing those erosions, which is using this kind of red dye. I don't use that very much myself. I tend to rely on the yellow one. But again, you can see that there's a speckling of the surface of the cornea with these red spots, and that's a staining. So that's why if you go to the eye doctor and they put these kind of funny colored dyes in, they're looking to see what they call corneal staining, which is a sign that the cornea is lacking adequate tear coverage. Okay. So the fix is simple, but a bit cumbersome. Maybe some of you have used, I wouldn't be surprised if a number of you have used artificial tears. The thing about artificial tears is they're not really a drug. Right? They're meant to create a kind of salt solution that mimics what your own body produces with a little bit of a gel-like quality to it. So they don't really have any active ingredient. They might have preservative, and people who are sensitive to preservatives should probably get the preservative-free versions. But other than that, they're pretty benign, and you can use them pretty frequently. And sometimes you might have to, which is the annoying part. Their effect may last an hour, or in some people only a few minutes, but it can be helpful to give a bit of relief from the discomfort from moment to moment. I find that usually when people use this, they don't use them often enough. I get patients who are using them once in the morning and once at bedtime. Well, hopefully when you're sleeping, your eyes are covered anyway. But in the daytime, you can certainly use them much more liberally. And sometimes a nice way to use it is to, if you're going to be engaging in a task that gives you discomfort, like if you're going out for a walk on a windy day, which tends to dry your eyes out anyway, or if you are going to be reading for a while and you know that if you read for after half an hour, you start to get uncomfortable eyes, well, put the drops in before you start. Give the eyes a head start. Yeah, and you can find some that have a bit more of a gel or viscous quality to them. The more viscous, the longer it'll last. So I'm not trying to advertise anybody, but these are some of the kind of artificial tears that are out there. There's certainly a lot of them, and I can't say I'm a connoisseur of all the different varieties, but there are certainly a number that can be tried, and I'm sure the pharmacists can give you advice as to which ones are perhaps more viscous out of the selection they have. So that's step one of treating dry eyes. If that's not enough, what we can often do is move on to these things, which are gels. Systane is not a bad one. I myself use Gen2. I find that works pretty well. I do a lot of cycling, and I get the dry eyes from being out on the road, so that's the one I use, but that's not a paid commercial. But this is something else that I find kind of helpful. The ointments are usually recommended at bedtime. Okay, they're kind of like, think of them as it's like a Vaseline for the eye. They're meant to be like a barrier cream. They are a bit goopy and greasy, and so the standard traditional way to use this is, well, if you wake up in the morning and you have a dry eye feeling, maybe that's because your eyes aren't properly closed at night. And so the treatment then, or the solution is to, well, why don't you put a barrier cream in to help your eyes stay closed and covered at night? And that's what these ointments do. So people put them in at bedtime, and hopefully that gets rid of the morning discomfort. I find, though, that actually you can use these in the daytime. It's always been taught that, well, if you use them in the daytime, because they're a goopy Vaseline cream, your vision is going to be blurry. But I find that if you use these in the daytime, a few blinks is enough to kind of give you a nice even smear of your eye, and the blur is pretty minimal. And it will give you much better and longer coverage than the artificial tears. So just a thought. Okay, so that's moving, we're moving up a ramp from increasing intensity of use here. If those things don't work enough, then another possibility is plugging your tear ducts. It's a kind of a simple mechanical idea. If you don't make enough tears, well, maybe you just plug the drain so they don't drain out of your eye so quickly. And that's what a punctal plug is. It's a little silicone plug that looks like that funny, it's not a metal thing. It's this kind of very rubbery thing that you then stick into that little black hole on the inside of your eye, just right beside your nose, and it will essentially slow down the drainage of tears. So hopefully whatever you make or whatever you put into your eye is going to stick around a lot longer. People have also tried these gel inserts that may last longer than artificial tears, and another treatment that people have sometimes used is a kind of it's a tear that contains a drug called cyclosporin. It's Restasis is the name of the trade name of the drops, but they contain an immunosuppressant that's often used for cancer treatment, which sounds a real sledgehammer solution. But the idea of using it is that you use a little local immunosuppressant because it may be that some inflammation of the eyes is preventing adequate formation of tears, and that's why you're getting a dry eye. So some of you may have had that as well if you have some significant blepharitis as part of the problem. So that's a short little tour through the world of dry eyes. So blepharitis is a kind of a 1-2 combination. If you have blepharitis, you're probably also going to get dry eyes because of the blepharitis, because this is an inflammation of the margin of your eyelids. That drawing there shows where the meibomian gland is, which is what secretes the oily part of your tears. That is the important part of lubricating your eye surface, as opposed to the watery stuff from the lacrimal gland, which is part of the reflex tearing stuff. So it's important to help prevent the evaporation of water. And it's also related to some other stuff that your skin does. Your skin also has an oily production, and some people with Parkinson's, I'm no dermatologist, but some people with Parkinson's do have a problem with seborrheic dermatitis. And this is kind of like a similar dermatitis-like affection of the eyelids that results in an eye irritation and tear film problems. So I'll show you some examples of this. Usually we look for this on the surfaces of the eyelashes, which are very close to the meibomian glands. And if you look on their surface here, you can see in that drawing there's the eyelashes where somebody's got their eye closed. And you see at the roots of the eyelashes there's that kind of the yellow flaky stuff. Right? It's kind of like dandruff of the eyelid margins. And also the eyelashes are a bit clumped. And if you look a little carefully around the base of the eyelids, you see that the skin is maybe a little bit red and maybe a little swollen. And that's a little uncomfortable. It's itchy. You know, and when you wake up in the morning, you have this crusting and matting of your eyelashes, so they kind of stick together a little bit. And you might even be aware of some of the flaking of the material around your eyelid. Some people do find with this, and I'm not sure why this works, but that they find that this makes them a little light sensitive. And again, because of the drying out and the decrease in tear production, they might complain of some blurred vision. I will show you a little close-up here. This is looking a little closer at that lid margin. You can see at the base of all the hair follicles, there's that crusty stuff. And the lid margins are also a little bit red. So you can often see this without using any fancy device. You just look closely at somebody's eyes, and you can see that this stuff going on. So obviously, you know, what you want to try to do is get rid of that stuff and try to get the meibomian glands a little opened up and get them to secrete the oily substance in a little bit more regular fashion. So some of you who may have had this will have heard the term lid hygiene. It's pretty simple, actually. This is all about getting up in the morning and getting a routine where you put a warm face cloth, not boiling hot, but nice warm compress to your eyelids with your eyes closed, and just leave it there and let it just kind of warm up and get those eyelids soaked. And then often just wiping gently across the lids from the nose outwards to help kind of remove some of that crusting material, get rid of some of that blockage. Often I find just in the morning may be enough for most people on a maintenance basis. If you're having a lot of problems, you might have to do it more frequently during the day as well until it gets under control. If you want to upgrade that, in addition to just a simple warm compress with water, you could actually put a little bit of baby shampoo on that as well to try to degrease the lid surface as it was. So if it's really bad, it's possible that it might even, you know, anything that gets blocked and a little stagnant can get infected. So people might get sort of a nasty version of this that requires actually antibiotics. And I haven't actually used steroids for this, but you know, it might be that more severe cases could use a little bit of anti-inflammatory as well. So that's the kind of uncomfortable, nasty, disgusting stuff that we hopefully would try to get under control and make life a little more easy for people with fairly simple treatments. Now, eye movements, this is where really, you know, when people get sent to a neuro-ophthalmologist is what we're often being asked to comment upon. There are some of these things that are common in all forms of Parkinsonian syndromes, including Parkinson's disease. And there are some forms that are present in some types, but not others, and therefore might be a useful diagnostic clue as to what type of Parkinsonian syndrome is going on in the given person. So let's start first, though, with convergence insufficiency. Some of the people who have this will, when it gets to a point where it's kind of obvious, the chief complaint that helps you diagnose it is that there's no problem looking in the distance, but if you try to look up close, as when you're doing reading or maybe looking at your dinner plate or whatever kind of near task you might be doing, you get double vision. And the images are side by side, not up and down. They're side by side. And if you close one eye, you're fine. You know, it doesn't matter which eye you close. Looking with one eye alone is not a problem, but with two eyes together, it doesn't work, and you got horizontal double vision. So if it's just starting, it might be super obvious that it's double. It might just look blurred. You know, if you've ever seen in the old days when they had newspapers and sometimes they didn't quite get the different colors aligned, you know, the print looks a little blurry. That's kind of the most minimal form of double vision. If your eyes are trying to work hard because your brain is trying to squeeze out that double vision, make it single, that takes a little effort. And if you're at the beginning phases and your brain is able to successfully do that, but it's putting a lot of effort into it, after a while, reading gets a bit tiring. And you might get a little bit of eye strain kind of discomfort if you're engaging in a near activity for too long, like reading. So that's the kind of symptoms that might tell you that, maybe you've got a convergence problem. And just to illustrate how this works, if you're looking at a faraway target, like when you're driving, you're looking in the distance at a car or something, then your eyes are kind of more or less parallel, and that's in order to point to the same place. But if you're looking at something up close, you need to make your eyes go cross-eyed to look at the same spot, like when you're reading the word orchestra there. So you can see by the arrows there and the eyeball figure, you're having to turn both your eyes inwards in order to look at the same spot. That's what convergence is, and that's what convergence insufficiency means. You don't do that very successfully. But because at far you're not doing that, there's no problem looking in the distance. So why do people with Parkinson's, why are they prone to convergence insufficiency? Well, we don't know. I don't think this is a dopamine problem, like the hypokinesia that maybe leads to decreased blink rate. But convergence does use neurons in the midbrain, and the midbrain is where there's a lot of pathology from, in Parkinson's disease. The substantia nigra is this black thing you can see in the anatomic diagram on the left-hand side. I don't know if you can see the midbrain there. I'm not sure if my mouse you can see it or not, but the cut portion there is the midbrain, and the blacky purple streak on the diagonals on both sides, that is the substantia nigra, and that's where the neurons in Parkinson's disease are taking the hit. But somewhere in that midbrain, and more towards the middle, is the area where the neurons are that you use to give the command to move your eyes together to converge. And it may be that some of the neuropathology and the Lewy bodies and stuff like that also spill over to affect those convergence areas there. Could double visions cause a spatial relation issue? Yes, and to some degree. If your eyes aren't pointing the same place, things are double, which means that your depth perception could be off a little bit. Because we often use, if you're stereoscopic depth perception, which is what you see when you go to a 3D movie, does depend on your two eyes being able to look at the same point but from a slightly different viewpoint, so that the difference in the image on the viewpoints is what gives you a sense of the 3D depth relationship. And so you can sort of get appreciation for that if you just cover one eye and try to figure out the depth of things away from you. You do lose a little bit of that depth feeling by having the one eye taken out of the picture. But you can get that back by just simply moving your head. Can it be because my left side muscles work different than the right? Not for convergence insufficiency. Convergence insufficiency isn't about a left versus right problem. It's about a command that goes out equally to the two eyes to have them work together. Do you have vertical double vision when looking at long distance? I can defeat this by covering or closing one eye. Does it matter which eye you close, though? If you have a vertical double vision and it's dependent upon having both eyes open, then that means that one eye is pointing slightly above the other one. But again, because it's vertical, that wouldn't be convergence insufficiency, and also because it's at far, right? So convergence insufficiency should give you a horizontal double vision when you're looking close, but no problem when you're looking at far. If you have cataract surgery, you might have a type of double vision. Well, there's a couple of things to think about, but the most common cause of double vision in relationship to some sort of refractive issue like cataracts and stuff is that the light is getting bent in your eye in some funny way. Possibly in the case after surgery, that there might be a little bit of scarring on the back. So the clue there is that the double vision doesn't go away when you're using just one eye by itself. It's a very important distinction. Double vision with one eye viewing by itself and double vision that only emerges when you have both eyes working together, right? That depends upon which of those two double visions you have, right? So someone asked, is there a solution for double vision? So if you have a double vision that is only in one eye, even when the other eye is closed, then that is something refractive. And the question is, what is it? What is not bending the light properly? Sometimes that's a simple glasses solution. Sometimes it might require cataract surgery. Sometimes it might require laser to the scar after cataract surgery. But the question is, what is it there about the way light is going through the eye? If you have a double vision that is only there when you have both eyes open, then it means because the eyes aren't pointing at the same location. And that is more of a neurologic issue. That's what I get involved with. Okay? And so if you have that, then one simple solution is just cover one eye. The other is to try to put a prism in to compensate for the fact that one eye is not pointing where the other one is. But we'll get to that in a second. So, okay. So if you have this particular kind of double vision, again, because it's a two-eye problem, you can either patch one eye when you're reading. So you take the other eye equation. If you only have one eye and there's no double vision when you have one eye viewing alone, well, just view with one eye alone. Or it's a bit more finicky. You can try to put a prism in your reading glasses to bend the light to compensate for the fact that the eyes don't quite come together. But you do have to get it exactly right, and over time it might change. But, you know, some people do like to try this, and it can be done if you're willing to be patient and work with it. You can put temporary prisms on, like plastic ones. Those cost about $50 to $100. If you want to get glass ground-in prisms, well, that's going to be a bit more expensive. And then some people suggest exercises. You know, kids have a problem with convergence, and exercises work really well with the kids, but we're not so sure how well it works for adults. So I'm going to say I'm not super impressed by the effect of exercises. You know, it's better to try to maybe just work around the problem rather than try to fix it, because I don't think fixing it works too well. And you know, in kids, we often will send kids for surgery, but we don't tend to do this with adults, especially if the problem potentially could change over time. An alternating exotropia associated with PD? No, not specifically. That if you have an exotropia at far, because what you're going to see with convergence insufficiency is an exotropia at near. But if you also have an exotropia at far, then that's not just convergence insufficiency. That suggests there might be something else going on. And one of the things you might think about there is something called an internuclear ophthalmoplegia, but that would tend to make you more suspicious that this is something different than Parkinson's. It might be progressive supranuclear palsy, because that does have an internuclear ophthalmoplegia with an exotropia. Okay, so you know, I'm happy to talk more about double vision towards the end, but we'll move on to the other thing that we commonly see. This is not something that people usually come to us complaining about, square wave jerks. It's a weird thing, but if you look at the diagram at the bottom, what we're showing there is the eye position, which is on the vertical axis, against time, which is the horizontal axis. So the dotted line is where the target is, the person is supposed to be looking, and the black line is where their eye position is. And you'll see, especially when they get to the top and the target moved towards the right, their eye followed. But then it has all these little positions where the eye gets taken off the target by a small movement and then goes back to it after time. So there's funny square movements. That's what it looks like. That's why they call them square wave jerks. So they're really small eye movements that take the eye off where you're trying to look. It doesn't take it a long way, but just a degree or two away. And then once your brain figures out that your eye moved out the target, it will make a correction and bring you back to the target. So it's almost like a little distractible eye movement that takes you away from where you're trying to look. We do see this with Parkinson's disease, but it's also normal to have some of these. Okay, everybody has some of these, but and somebody who doesn't have any problems and is young, probably no more than about 10 to 12 per minute. But and it partly depends on how bored you are as well. But if you have a Parkinsonian problem, then you're going to have more of these, and they're also going to be bigger. And if you have progressive supranuclear palsy, a kind of Parkinsonian syndrome, that is very prominent in that condition for some reason, which we don't really understand. You would think that people would notice this as maybe a little jiggle of the eye, but it's very few people that actually are aware that their eye is being taken off the target, because it's so small, I think, and the brain does get information that the eye is moving, so it knows it's not the world that's moving, it's the eye that's moving, and it compensates for that. But the one thing people who have a lot of these notice is that it's a little bit hard to read. It takes them longer. It seems like their eye is always kind of bouncing around the page a bit, and when it does that, the reading speed does tend to go down. Not impossible, but just slows things down a bit. So this is the video I wanted to show you of that Miriam's going to show. If you watch this woman, she's going to be trying to keep her eyes steady, and we'll just play that there, and you watch. Go for it, sure. Well, this is a bit jerky, but anyway, see that little sideways movement, that little. Yeah, you can see them there. Sorry, it's a bit jerky, but you get the idea that there's these little horizontal wobbles to the eye, even though she's trying to keep her eye really still. Okay, we'll go back to the slideshow. So that's essentially what square wave jerk is. It's small, and you can see it's not a big deal, but it's a pretty frequent finding. So we don't really have a way of treating this. I mean, it's a bit overkill, but there are some thoughts that square wave jerks can be decreased by the deep brain stimulation techniques that some people have used in Parkinson's. I think for me, a simple thing I tell people is that if your eyes are jiggling around a little bit, well, the effect of that jiggling on your reading is going to be minimized the bigger the text you're reading. So reading larger things with a magnifier or something, or using just getting bigger text, somehow it would minimize the impact of that on reading. It sounds like a simple, dumb idea, and that's exactly what it is, but it does help if it's interfering with your reading. Okay, vertical gaze palsy. So what this refers to is the fact that we are all able to move our eyes in 360 degrees of directions, but sometimes moving the eyes up and down is a particular problem, and that is particularly the case and the clue to the diagnosis of a condition called progressive supranuclear palsy. I mean, it's only one part of this condition, but it's important enough that it actually achieves this kind of billing in the name of the condition. Supranuclear palsy refers to the idea of this gaze palsy. What supranuclear means is that this is every nerve to your eye comes from the brain, and it comes from a place in the brain called a nucleus. That's where the cell bodies for that nerve lie. Supranuclear means that the problem isn't with that nerve or that nucleus, but it's behind that. So it's to do with the command structures that give a command to the nucleus to tell your eyes to move. So that's what supranuclear means. So, and the vertical and horizontal gaze have different command systems in your brain, and in progressive supranuclear palsy, it is the vertical gaze commands that take the hit early on. So the clues for us as neurologists that you might have this thing rather than Parkinson's disease are a number of things, such as early falls, not much tremor, and the stiffness and the rigidity is primarily focused in the neck and the back rather than the arms and legs. And if you try Cinemet or other kinds of L-dopa stuff, not much improves. So those are the kind of things that usually lead a Parkinson's disease specialist to send their patients to me to say, what do you think about the vertical gaze? Because I'm suspicious that this might be progressive supranuclear palsy. So what are the kind of things that you might notice if you have the vertical gaze palsy? Well, looking down is particularly the direction that gets hit early and the most severely. And when do you tend to look down? You look down when you're trying to read. That's especially with books. Computers, if you have things properly positioned, you're probably looking more straight ahead. Going downstairs, you like to see where your feet are going. And then eating meals. There's this weird thing called the dirty tie sign, where essentially people who can't look down and they're trying to essentially make their best guesses of where the food is and where their spoon is, sometimes make mistakes and they get food over their shirt and their tie, if you're a guy. So one of the double whammies for this condition is that not only can they not move their eyes down, but because there's a stiffness in the neck and the back, they can't bend their neck either. So they really can't move either their head or their eyes downwards. And so, the ability to look at things in the lower part of their world is really very difficult. So again, I'll show you a short video showing somebody who has this kind of problem. And this is somebody who had progressive supranuclear palsy, and they have a little bit of a stare where the eyelids are a little bit wide and wider than it should be. And as they look to the sides, you can see that they can look left and right pretty well. If I get them to look up and down, You see, when they try to look up, the lids go up. They try to blink to get their eyes up, but the eyes really just don't move. And when they try to look down, you should be able to get the pupil, which is the dark part of your eye, to meet the lower lid, but it just doesn't get there. When they follow a moving target, it doesn't seem to make much more difference. Where sideways, you can see they're really good. So it's a dissociation where horizontal gaze works really well, but vertical gaze doesn't work very well. That really tells us that something like this is going on. So it's an important diagnostic clue because, again, if you have this condition, probably the therapeutic options are different than in Parkinson's disease, and the kind of things that you can expect as time goes by are also going to differ. So what can you do if you have trouble looking up and down? Well, we can't unfortunately fix your eyes with any kind of medication if you can't move up and down. There's a couple of things you can try to get by. If you put prisms in your glasses, it's possible to try to bend the light so that wherever you're looking, you can actually look a little further down just because of the prisms. Or if you can't move your eyes down, well, move whatever you're looking at up. And that's where people often will read with something to hold the books a little up, just like where the computer would be. Or reading books on computers instead, on the screen and Kindles and stuff like that. So the last thing in this section, ocular dyskinesia. If you have Parkinson's disease and you get treated with dopaminergic medication, some of you might be familiar with the fact that there will be times when maybe there's too much L-DOPA in your system, and so you get this dyskinesia. You get you're very freely flowing and moving, but you're probably moving more than you want to. And then you might cycle down to an off phase where you don't have enough L-DOPA in your system, and then you're back to having all the stiffness and slowness of Parkinson's disease. So this kind of on phase or dyskinesias with the limbs where you're flowing freely and excessively can happen also in the eyes, and so that your eyes also kind of move more than you want them to. Most of the time, this is not a big deal in the point of view of symptoms, fortunately, because it's transient and doesn't, cause prolonged deviations or difficulty in looking where you want to. Interestingly, if you have a subthalamic stimulator and you turn it on, there have been times when people have noticed that it causes their eyes to deviate to the other side, which is more of a problem. So I'll give you an example. I forget which side it was, but they often go up to the left and up or right and up. That's a common direction that they tend to deviate. Okay, is it still frozen? Oh no, here we go. Okay, so the last thing I wanted to finish up on was, we talked about the surface in the eye, we talked about the eye movements that can happen, strange things that can happen with eye movements in Parkinson's disease, but the whole vision idea, is it possible that something could also happen in vision itself, the way you see? And this is perhaps, some of these things are a bit more contentious and perhaps are more on the research side, but they're kind of interesting ideas anyway. So for example, could there be something with the retina that is funny in Parkinson's disease? Now, why should we expect that? Because some of the cells in the retina actually also use dopamine as a neurotransmitter. And there's these things called amacrine cells. Now, the diagram there shows you a cross-section of a retina. At the top is the choroid, which is kind of the outside. That's kind of like the blood supply and stuff. And there's a pigmented layer that is like the backdrop to absorb stray light. And then in front of that is this section that is labeled the outer segments of the rods and cones on the screen. That's where the real photoreceptors are. And those are in cells whose nuclei, where all the machinery and the DNA resides, is in that big thick layer of blue circles. Now that information then gets transmitted through a relay of other neurons down to the bottom of the layer of that screen there, which is the retinal nerve fibers that then leave the eye. But some of that relay information is modulated by these cells that are called amacrine cells, which are in that last layer of blue dots. And exactly how they, well, anyway, I won't get into the details of what they actually do to modulate the information being transmitted from the rods and cones to the brain. But there is some theoretical reason to believe that if you have some loss of dopamine here, it could affect some properties of vision a little subtly, such as the acuity, maybe even color vision or contrast sensitivity, which is the ability to tell subtle differences in gray. But that's all still kind of, like I said, primarily a research idea. We don't really know how much this translates into clinical complaints. Certainly, I don't see a lot of people with Parkinson's who complain of color vision loss. It is possible to look at this structurally these days. We have this tool called optical coherence tomography, which can give us a cross-section of the picture of the retina, and can even show us all the different layers of the retina. Things that were really not possible before. And so there's been a lot of interest in trying to see, well, is it possible to show that there are loss of retinal nerve cells in Parkinson's disease that would correspond to this idea? And I think that the jury's still out. I've certainly done a project on this over the last couple of years with a fellow from Switzerland, and we actually showed that, if anything, there's more thinning of the retina in progressive supranuclear palsy than in Parkinson's disease itself. So there's more to be learned from this, I think. Of whether or not it can actually be used as a way to diagnose and differentiate different kinds of Parkinson's syndrome, I think we still need to figure out how good a tool would be in that respect, especially when things are early and we're still trying to figure things out in a given patient. How about the brain? This is kind of interesting to me. I spend my life looking at brain, how the brain manufactures vision. That's what my research lab does. And I've been interested because we do a lot of work with reading and face recognition and spatial navigation. And it's curious that from time to time I find people reporting that there are indeed problems in identifying faces or facial expressions or spatial navigation in people with Parkinson's disease. But I will say, from what I've seen, this is nowhere near as severe as what I normally see when people have had strokes or brain tumors or brain infections and have lost these networks. It's not that degree of severity. This is more of a more subtle, slight decrease in accuracy or reaction time kind of thing. So suggests that, yeah, maybe there is some hit on these kind of networks, but it's not a major issue like we see in other diseases. It's possible that if you have this kind of funny variant called diffuse Lewy body disease, Lewy bodies are these funny little spherical things that we see in the midbrain in people with Parkinson's disease. And in some people, it's much more widespread, and also in the cortex. And perhaps in those people, there might be more of an issue with these kind of issues because the pathology is a bit more in the brain as well as just down in the midbrain. That also brings us to this last point of hallucinations. It does happen. I'm not sure how many of you have experienced this. They're they're exclusively visual, and they're often complex. What we mean by complex is that they're actually forms and shapes and things that you can identify, like the face of somebody, or like a car, or people coming into your room, rather than just kind of vague swirls and shadows and stuff like that. We do know that if you have this, or if you have certain factors, you're more likely to experience hallucinations, and things like how long you've had Parkinson's, how severe it is, if you have other factors like depression and insomnia, and if there is some cognitive impairment as well. And those factors aren't necessarily exclusive to Parkinson's disease. We know that people who don't have Parkinson's but who do have cognitive impairment are also prone to having hallucinations. There is this kind of suggestion that it might be related to the problems with REM sleep that we've all learned about more in recent years about Parkinson's disease. That REM sleep disorders are. REM stands for rapid eye movement, by the way, and it's like when you sleep, you often go into a deep sleep, and then you have these periodic semi kind of reversals of that deep sleep during the night, in which the brainwaves speed up, but you don't move, but your eyes move a lot. And it's often a time when there's a lot of dream function going on. And if you have a disruption of that process, this might be also associated with hallucinations in the daytime. So the other possibility is that it's not to do with the direct pathology of Parkinson's that affects this REM sleep disorder in the midbrain centers, but it could be a side effect of medication as well. So that's often a tricky point where we have to kind of try to sort out, is the hallucination because of the problem or is it because of the treatment? And then, there's the issue that, well, if it's part of the problem, is this enough of a problem that it's indicating that this is a diffuse Lewy body disease problem? Because diffuse Lewy body disease is this thing where you have Parkinsonism, you have sleep-wake cycle reversals, so that you're awake in the night and you're asleep in the day and drowsy. There's episodes of confusion, and 90% of people have actually hallucinations. So where is this coming from? Well, again, this probably is more of a cortical problem than a midbrain problem. It may be more in the anterior temporal lobe, but we don't know that for sure. The other possibility is that it is a midbrain thing, but it's something to do with the projections that are important in REM sleep control, and the hallucinations are a bit of a byproduct of that. How can you treat these? Well, one thing is, if there is any medication that you think could play a role, well, that's an easy fix. If it's possible to remove that drug, that would be great. And see what happens. There's an interesting idea that, well, is it something to do with visual deprivation? We know that people who don't see well, like if you have bad cataracts, for example, you might actually hallucinate in the presence of bad vision in both eyes. But 40% of people, for example, who've had strokes in the brain that lose half their vision in both eyes will have hallucinations just because of the loss of vision. So if you have some visual deprivation, maybe fixing that would reduce the likelihood of getting hallucinations. And finally, people have always played with drugs that we use for Alzheimer's or REM sleep disorders. I have not done it personally, but reportedly there is some effect of these as well. So that's it. That's my tour through the eye and eye movements and vision in Parkinson's disease and Parkinson type problems.